u vreme četvrte industrijske revolucije. Okruženi smo pametnim uređajima, koristimo virtuelne asistente. Svedoci smo vrtoglavog razvoja veštačke inteligencije. Oko nas sve vrca od pameti i inteligencije, a mi još uvek ne možemo da razumemo i obuzdamo sopstvene misli i osjećanja. Prema poslednjem izveštaju Svetske zdravstvene organizacije o mentalnom zdravlju, svaka 8. osoba na svetu se suočava sa problemima mentalnog zdravlja. Da li su kriterijumi isuviše široko postavljeni ili su objektivni događaji doprineli pogoršanju mentalne stabilnosti, tek prema istom izveštaju, u prvoj godini pandemije koronavirusa zabeležen je porast anksioznosti i depresije za 25%. Upravo na ove izazove savremenog života odgovara kognitivno-bihevioralna terapija, skraćeno KBT. To je najzastupljenija psihoterapija na svetu. Fokusirana je na efikasno rješavanje trenutnih problema. Počiva na stavu da nisu događaji ti koji nas uznemiravaju, već način na koji ih tumačimo. Mnoga istraživanja pokazuju da KBT daje dobre i merljive rezultate. Zato ne čudi što je 54. kongres Evropske asocijacije kognitivno-bihevioralnih psihoterapeuta nedavno održan u Beogradu izazvao veliko interesovanje. Preko 1500 učesnika sa svih strana sveta došlo je da čuje 30 poznatih predavača i terapeuta koji su kroz radionice, predavanja i diskusije govorili o preko 30 tema, od anksioznosti, depresije, menadžmenta besa, bipolarnog poremećaja, preko poremećaja u ishrani, obsesivno-kompulzivnog poremećaja, pa sve do digitalno asistirane psihoterapije.
I'm a professor at the University of Oxford, and I also run something called the Highly Specialist Anxiety Disorders Clinic, also in Oxford in the National Health Service in the Warneford Hospital. I've been working for more than 40 years on the treatment of anxiety problems, developing new treatments, and then trying to roll those out for the people who really need them. The reasons that I do cognitive behavior therapy is because I started my career in psychology at a time when there was very little evidence. The first stage of evidence in psychotherapy was behavior therapy, and the other psychotherapists quite angry about this, that we were claiming to have evidence and so on. Now that was an evolution really between behavior therapy and cognitive therapy. And again, it was both evidence-based and empirically grounded. And what that evidence-based means is that the treatments can be shown to be effective in randomized controlled trials. Very important that. But also, we can't do randomized trials for every possible combination. So we have to understand a little bit about the processes underpinning it, what's going on underpinning it. And so we can, from other studies, then strengthen the research that we already have. In cognitive behavior therapy, the evidence is that it will help your symptoms a great deal. It won't necessarily change your personality. However, if you do, say, psychodynamic or psychoanalytic psychotherapy, the aim is in fact to change your personality. It probably doesn't work, but that is the aim. And so it's really important that you understand what it is that you're buying. And one of the things about people who are seeking help with mental health is they often don't know what it is. So it's really important that we share with them what it is that's done and what the evidence underpinning it actually is, so they can make the choice, not me.
The research that we have has demonstrated that cognitive behavioral interventions, therapies that change the way we think and directly try to change the way we behave, are the most effective interventions. Lots of other psychotherapies have never really been tested with Anchor. It's like people don't want to, I don't know, maybe they would work, but people haven't tested them. Or maybe the people who do those kinds of therapies don't think that they would work. But cognitive behavior therapy clearly is the thing that works the best.
To je danas najpopularnija terapija, najviše postoji KBT terapeuta. Na primjer, u Evropi KBT terapeuta ima koliko i svih drugih psihoterapeuta zajedno. Znači, tako da definitivno smo najbrojniji i ta terapija se pokazala kao najuspešnija. Naravno, ne može da pomogne svakome kao ni jedna terapija. Znači, imate ljudi koji prosto, znate da je, mi imamo vic, koliko treba psihologa da se promeni sjelica, mora sjelica da želi da se promeni. Što znači, donekle smo, za razliku od zubara i lekara koji mogu samo da rade, bez obzira šta će pacijent da kaže, mi zavisimo dosta i od klijenta. Odnosno, ako on ne uloži trud i energiju, sve naše znanje i sve je uzalud.
Kognitivno-behavioralna terapija nastala je kao spoj behavioralne terapije koja se fokusirala na promenu ponašanja kroz učenje i kognitivne terapije koja je istraživala kako misli utiču na osjećanja. Aaron Beck, američki psihijatar, 60. godina prošlog veka razvio je kognitivnu terapiju kao način tretmana depresije. On je primetio da depresivni pacijenti često imaju negativne obrasce razmišljanja koje je nazvao kognitivne distorzije. Beck je verovao da promenom tih negativnih misli možemo uticati na promenu emocija i ponašanja. Paralelno s tim, Albert Ellis, drugi pionir u ovoj oblasti, razvio je racionalno-emotivno-behavioralnu terapiju, skraćeno REPT. Ova terapija se fokusirala na identifikaciju i promenu iracionalnih uverenja koje dovode do emotivnih i ponašajnih problema. Tokom decenija KBT se razvijala, proširivala i uključivala nove tehnike i pristupe.
I'm a clinical psychologist from Canada, and I've had the privilege of being the president of the Canadian Association of Cognitive and Behavioral Therapies, and just recently I finished a term as the World Confederation of Cognitive and Behavioral Therapies, the presidency as well. So I've been involved in the field for many decades. I think one of the advantages of the cognitive and behavioral therapies is that we have tailored techniques for different problems. So we know, for example, for many of the anxiety disorders, that there are a set of interventions that will help many people. So the question is, how do you get that intervention to people in a way that they understand and that they will adopt themselves? So that's where the relationship becomes important. So like I say, it's not just what you do with people, but how you get them to engage in that process too. One of the metaphors I sometimes use when I do training is what I try to do in therapy is get people to become experts in CBT themselves so that they understand the treatment and they can apply it to themselves and they learn the skills and the methods.
Is it demanding?
Absolutely. It's very challenging, in fact, yeah. And again, it's based on a positive relationship and a client who wants to learn and to develop as well, which most people do.
Ja sam završila osnovne i master studije na Filozofskom fakultetu u Beogradu u okviru psihologije, master mi u okviru psihologije rada, ali dodatno se edukujem u oblasti racionalno-emotivne i kognitivno-behavioralne, odnosno REPT i KBT psihoterapije i sada sam na završnom nivou. Tako da sam i psihoterapeut, radim kao psihoterapeut pod supervizijom. I na ovaj kongres sam došla zato što stvarno predstavlja jedinstvenu priliku da se umrežimo i sa kolegama iz inostranstva, da podelimo neka različita iskustva iz obrazovnog konteksta, iz poslovnog konteksta, ali najviše iz klinike. Ono što je meni negde bilo posebna motivacija da dođem jeste i predavanje Raymonda Di Giuseppea, koji je autor iz čije literature i članaka sve vreme čitamo. On je ceo svoj rad posvetio negde problemima i tretmanu besa, što je negde i dosta zanimljivo jer se bes kao negativna emocija negde stavlja, kako je i on to sam rekao, na neki kraj. Ne tretira se kao depresija, kao anksioznost u kliničkom kontekstu, već je to uglavnom na edukacijskom i preventivnom nivou, a bes stvarno može da predstavlja velike probleme za ljude i za njihovo svakodnevno funkcionisanje.
Profesor kliničke psihologije Raymond Di Giuseppe sa St. John's univerzitetu u Americi razvio je procedure za dijagnostiku, procenu i primjenu KBT-a u upravljanju besom kod dece i odraslih.
We developed a scale called the anger disorder scale. It's anger as a clinical problem. And it develops different subscales to look at how we're best going to treat people. And we have collected data on that scale for about 2,000 people. We've done lots of statistical analysis for different types of anger problems. But we look at anger characteristics, or the characteristics of anger, and we have scales on it. This has been a major problem because until our scale, most people didn't agree on what were the characteristics of anger. So we measure, do you When you're angry, do you want revenge? When you're angry, do you use your anger to control other people? Do you have resentment for being treated bad in the past? Are you suspicious of other people? You know, do you hold your anger in when you're angry, which is very common? Do you engage in passive-aggressive behavior when you're angry? So we have about 18 different characteristics of anger that we assess. And we're now developing profiles of different subtypes of anger disorders. And we see, very interesting, that some people, when they're angry, they really are more vengefully angry. And they do all kinds of aggression to hurt the person they're angry at. And other types of people, we found they're more power-related. They want to control their employees, their friends, their lovers, their children, and their anger is more coercive and controlling. And they don't engage in as many aggressive behaviors. They're mostly loud and screaming. We have some very interesting age results from this. When you're 8, 9, 10 years old, you're not so angry. It kind of raises when you're early in your teens. 13, 14-year-olds, they're really angry. And then it sort of drops down. Then we get into the adult scale, and anger drops as you age. So there's hope for people. You know, age brings maybe wisdom. And then we have a big jump in anger at around age 65. We don't really understand why that is. I think it is that that's the time when people expect you to retire. They expect the next generation, and we don't want to give it up. So we do have some interesting age reactions or changes with anger. We try to sort of change what is it that you think, and let's develop an attitude of any idea that I have could be wrong, could be a better one. How do I logically analyze those things that I think? How do I test out whether my ideas are consistent with reality? You know, how do I develop a different attitude? Who has a different attitude that may be better off? So, for example, I was mentioning this idea that people who think I must look tough in front of others are more angry. What we've discovered just recently, in a poster we presented recently, if you really accept yourself and you don't rate yourself as a good, bad human being, I'm just a good human being, you're less threatened by what other people think of you, and you're less likely to have to look tough in front of others. So right now we're sort of working on this idea of trying to teach people self-acceptance. I'm a person, I don't have to compare myself to others, and if you don't like me, it's none of my business. I don't have to worry about it. So that's what we try to get people to think.
Jedan od primjera efikasnosti KBT-a je činjenica da je to terapija izbora kod lečenja obsesivno-kompulzivnog poremećaja, koji karakterišu prinudne misli i ritualna ponašanja. Ovo je ilustrativan primjer jednog anksioznog poremećaja kod dece, adolescenata i odraslih, sa kojim se KBT uspešno nosi.
If somebody has obsessive compulsive disorder, there are really only two treatments, one which are shown to be effective, one of which is medication, which of course has problems, the other of which is cognitive behavior therapy. And of course, this is true both for adults and children, but in general, we do not want to give people with a developing brain, children, psychotropic drugs, drugs which change the way their brain develops. So for children, in fact, CBT is pretty much the only appropriate treatment to offer. So it's based on the idea that everybody has thoughts which come into their head, unpleasant thoughts, thoughts of, say, pushing somebody in front of a car or driving a car into oncoming traffic or doing something uncontrolled. So that's a very normal thing. People with OCD, what's happening is that they're thinking they're more important, these thoughts are more important than they really are, and they struggle against them. So what we're doing in therapy is helping people understand that process and helping them actually start to try out reacting in different ways. So we don't tell them what they're doing is wrong, but what we say is, well, let's see what that might be doing to you, and then let's try a different way of doing things and see if that might be slightly better. So the technical term is we try to help people be more cognitively flexible, means flexible in the way they think, so they can see things in a different way. So that's the basis of cognitive behaviour therapy. The principle is simple, but the practice of it, dealing with people who are very disabled, who've been suffering from these problems for many years, is much more difficult. And so one of the things I was saying today is that you have to make a human connection to people. The therapeutic relationship is an important part of any therapy. And what we say in cognitive behaviour therapy is that it's necessary but not sufficient, meaning you have to have it, but on its own it's not going to be enough. Now that's different from other psychotherapies. So most other psychotherapies say that the mechanism of change, the way that people change, is by having a relationship with the therapist. So if you're a psychoanalyst, then the psychoanalyst sets out to have you fall in love with them. And then when this is called transference, and when that happens, when you recreate your childhood experiences, then they're able to help you deal with those differently and help you move on in your life, particularly in terms of your personality. That's not what we do in cognitive behaviour therapy. So what we do in cognitive behaviour therapy is we try to get to know the person before we get to know the problem. And then once we have a shared understanding, which means the therapist and the patient actually make sense of the problem, they sit down and work it out together, then the patient can then choose to change. The other thing is that with things like obsessive compulsive disorder, we know that one of the main mechanisms that keeps it going is people avoiding and doing neutralizing behavior, and they have to overcome that. One way of doing that is to help people to confront their fears. Now, if somebody's afraid of contamination, okay, so they're afraid of contamination and it's a big worry, and we want them, for example, to touch the floor, then one of the things we might do is to say, well, we'd like you to touch the floor. Before we do that, I'm going to do something, which is, in order to, if it's okay with you, what I'm going to do is I'm going to lick my shoe. And that shows that essentially on the floor there's nothing to be worried about. And so in doing that, it makes it possible for the patient not to lick their shoe, but to touch the floor, to confront their fears. And what we're doing is we're supporting people in the process of confronting their fears, and we're literally putting our money where our mouth is, or putting our shoe where the mouth is. So what we're trying to do is to demonstrate to them that we're not just telling them to do something which is unreasonable, but we're prepared to do it first. And one of the principles I would say is don't ask your patient to do anything that you're not prepared to do yourself and a little bit more.
It is very demanding for the therapist, I think.
I've not been sick so far, but it's only been 45 years since I started doing it, so maybe there's a chance for it yet. It is demanding, and some therapists, for example, can't do it. But then, if a therapist can't do it, should they be asking their patients to do it? And that's an issue in my mind. We should not be hypocrites in our therapy. So we should be prepared to front up how we are going to do things, and then we can ask the patients to. We earn the right, if you like, to suggest things that they can do.
Možda je ovo ekstravagantan primer ličnog angažovanja psihoterapeuta, ali je poruka sasvim jasna. KBT od terapeuta, osim znanja, zahteva inicijativu i posvećenost u radu sa klijentima. Da li zbog zahtevnosti posla, povećane osetljivosti i brige o mentalnom zdravlju ili zbog porasta broja problema sa kojima se ljudi u savremenom svetu suočavaju, tek činjenica je da psihoterapeuta nema dovoljno.
We right now have a psychotherapy mental health crisis, and for a couple of reasons. I think that we're finding more young people developing mental health problems, and there's not enough therapists to help them. We can't train therapists fast enough. We can't find enough financial support to pay for the therapy. The insurance companies and the governments don't always want to provide sufficient funding. So in America, we really may have more psychotherapists than lots of countries, but it's really not enough. And the big debate is, what is happening in modern society that is causing children and adolescents to have more mental health problems? And the big debate is Is it the parenting practices? Is it the way parents treat their kids? You know, we're so protective with our children. We don't want them to go out and walk the streets or ride their bike in the neighborhood. We have to watch them, so we're not training them for independence. Or is it social media and the phone? So that's the big scientific debate right now. And we're kind of struggling with how to develop better ways of delivering service because we don't have enough.
There's two things going on. There's a more challenging world than there was before, but there's also diagnostic creep, so we're over-identifying. So some of the estimates in terms of self-identification is that 70% of young people have mental health difficulties. Now, 70% of people, of course, at times have mental health. You at times will have mental health difficulties. That's entirely normal. But it doesn't mean we have mental health disorders. So again, the over-medicalisation is a problem here. So we need to think more clearly about those things that can be changed and should be changed, and those things that couldn't, because we can't offer psychological therapy to 70%. And indeed, it would be wrong, because the other thing about psychological therapies is they can cause harm. That if you have the wrong therapist, that they can cause harm. I mean, there's been some discussion about psychedelic therapies. I'm quite concerned about this, because I'm not sure that I would want a patient, you know, who perhaps has some history of drug use, to then be given ketamine to help them with their depression, for example. It's not a good thing. So there are clear dangers there, and these have been somewhat documented. So there's all kinds of risks in the way that we deal with this, and I think it's important, therefore, to follow the evidence. And that evidence means balancing the harms of what we do with the benefits of what we do, as well as the costs, because costs are not.
We have many, many global surveys of mental health, and the number one and number two issues globally are anxiety disorders and depression. The anxiety disorders, there actually are several of them. When you put them all together, they're the largest group, but the single largest diagnostic category is major depression. So those two conditions together account for about 50% of the mental health problems we see. And then you run into many, many other problems like attentional disorder, schizophrenia. You know, there's a wide range of, there are over 500 diagnoses in our diagnostic system. So when you put them all together, you know, they add up. And many people, unfortunately, suffer not from one condition, but they have what we call comorbidity. So they have more than one condition. One of the virtues of CBT is it's been evaluated extensively. And in fact, if you distinguish CBTs from the earlier models of therapy, that was one of the earlier distinguishing factors, the evidence base that was developed. And if you look at the outcome literature now in the field, for many conditions, CBT is either one of the evidence-based therapy or the dominant approach.
U Srbiji je psihoterapija gotovo u potpunosti u domenu privatne prakse. Tako je i sa edukacijom. Budući terapeuti nakon osnovnih studija pohađaju višegodišnje licencirane obuke i prolaze neophodan period supervizije i sve to samostalno finansiraju.
Mi imamo dosta stručnjaka i edukujemo sve više i u KBT-u i naravno i u drugim vrstama psihoterapije, ali to je opet nedovoljan broj ako govorimo o potrebama celokupne populacije Srbije. Znači mi tu daleko zaostajemo, ali eto, radimo sve što možemo i Ministarstvo nauke, na primjer, isto pomoglo, odmah su prepoznali da je ovo važno i pomogli su nam. Tako da mislim da, s time što dalji neki napredak toga u Srbiji će zavisiti od donošenja novih zakona o psihoterapijskoj delatnosti, novih zakona o psihološkoj delatnosti. Te stvari bi mogli da promene zaista pravljenje komora, kao što to imaju pravnici i lekari. To bi uredilo sistem i omogućilo da više nemate one ljudi koji odu 2 sata na neki kurs i onda kažu da su psihoterapeuti. Tako da nama je to važno pre svega da bi zaštitili ljude od prevaranata. Mi imamo stručnjake, imamo ljude koji su obrazovani i ovde i u inostranstvu i oni su dobri i čak izvozimo naše usluge za inostranstvo jer potreba je velika, a Amerikanci bi radije platili naše terapeuti koji su jeftiniji nego tamo čekali ko zna koji red da dođu na terapiju.
Govorite o terapiji online.
Terapija online koja se sad proširila nakon korone je postala nešto što je uobičajeno. Ranije to nije bilo toliko prošireno, ali sada su skoro svi to usvojili.
Samo da ne bude nesporazuma, samo licencirani terapeuti su terapeuti koji mogu da pružaju ovaj usluge.
Apsolutno licencirani, s time što, znači, za sada mi to rešavamo tako što licence dobijemo iz inostranstva. I mi sve imamo licence iz Njujorka, iz Britanije i tako dalje, ali praktično ovi naši srpski sertifikati, mislim, nama su oni važni, ali oni ne predstavljaju, nisu nikako zakonski prepoznati. Tako da zato kažem, komora bi nama rešila taj problem.
One of the challenges we have in the field is really about the whole question about what is psychotherapy and who can provide it. So different countries in Europe and then also around the world have different standards for who can be a psychotherapist. And this has become a real challenge for us about when we do training, who should we train, how should we train them, what licensing do they have, what legal, ethical standards do they hold up, and so on. And again, you know, this has become a real challenge. So we're starting to develop standards even within the CBT community about what is adequate training, what does that look like, and how should we recognize a CBT therapist. One of our issues, unfortunately, is that because CBT is so successful as a model and it's getting known more and more around the world, many people claim to do this therapy even if they're not well trained. And so, you know, the issue about training and credentialing has become more and more important.
Kognitivno-behavioralna terapija nastala u Americi brzo se proširila na Kanadu, Australiju i Evropu, a danas se polako probija i u druge delove sveta. U mnogim državama ova vrsta psihoterapije je dostupna u okviru zdravstvenog sistema, što svedoči o razumevanju značaja mentalnog zdravlja za dobrobit pojedinca i celokupne zajednice.
One of the things that I really appreciate is the fact that CBT works for depression, that it works cross-culturally. In fact, like I was mentioning before, it works better in China than in other countries, and I've been in China many times doing training there. And so for me, the excitement and the growth of the field has been truly amazing. It's something I never would have imagined 30 years ago, but you know, to see it now is just incredible. We were just at a reception here and you couldn't hardly get in, right? So it's amazing to see the growth in the fascination and interest in the field.